by saying that there are certain practices that they can no longer engage in. And then there are other practices that they have to engage in, designed to be more beneficial to patients. Insurance companies in a private for-profit system are going to be motivated to charge the highest possible premiums, co-pays, and deductibles. They make their money by collecting premiums and co-payments. And they hang on to that money by forcing consumers to pay deductibles and by denying claims. That's their business model, in a sense. Drug companies. Drug companies in a private for-profit system are going to create new drugs, which they do very well. They're going to create demand for drugs. We see now, and this was not the case, I could tell you, when I was a college student. We now see commercials on television, advertisements for prescription drugs. Do you have this condition? Talk to your doctor. Have your doctor prescribe this new drug, creating demand for drugs. And they, of course, are going to charge the highest possible prices. I gave you that one egregious example of the drug company, I forget the name of the company, owned by Shkreli, who jacked up the price of a life-saving drug by an unconscionable amount. Well, that's our system. Get the most, earn the most profit that you can. Patients. We limit our use of healthcare based upon our ability to pay for it. Even if we have health insurance, it costs us. You go to a doctor, you have health insurance, let's say your deductible is already covered. You still are going to have a co-payment that you're going to have to make to the doctor, which could be $25. The doctor most likely is going to, if you're sick, is going to write you a prescription for something. You're going to have a co-payment there. That's going to be another, whatever, 25, 30, 15, whatever it is. There's going to be a copay. And then you're going to have to go back to the doctor and be checked to make sure that you are now, over whatever it is it was. So even with health insurance, that trip to the doctor's office is going to cost you anywhere from $50 on up. Lots of people can't afford that. If you have a deductible, a $3,000 deductible, well, that means the first $3,000 worth of medical bills in a year you have to pay out of pocket. And there are lots of people who are not in a position to lay out $3,000 for medical bills. So we don't use the healthcare system. And you can argue, and I would argue, that American hospitals and doctors are among the best, if not the best, in the world. That's not in dispute. But if you can't access it because you can't afford it, then it doesn't do you a whole lot of good. Ferrari makes a great car. I would love to have a Ferrari, but I can't. I can't afford a Ferrari. So the fact that Ferrari makes great cars, that doesn't do anything. Yeah, that's nice, but it doesn't do anything for me because I can't access those vehicles. We, as patients, use only those healthcare providers approved by one's insurer. We are limited in our choices. Let's be clear on that. Technically, I could go to any doctor I want. Practically, I'm only going to go to doctors that accept my health insurance. Every health insurance plan has what's called a network of providers, doctors and hospitals, as well as other kinds of clinics and rehab facilities and so forth. And you use, as a patient, you use those healthcare providers. So if someone were to tell me, oh, we got this great doctor, he'd be perfect for you, but he's not in my insurance network, I'm not going to use that doctor, because I'd have to pay that doctor quite a bit of money, because my insurer would not cover it, or would cover it at a very low percentage. So our choices are very much limited by our for-profit system. Those without the ability to pay use hospital emergency rooms for primary care. This is the most expensive way, the most expensive place to get health care is in a hospital emergency room. But if you don't have health insurance, private doctors will not take you. Private hospitals will not take you. But public hospital emergency rooms have to take you. So people without the ability to pay are going to rely on the most expensive form of health care as their primary care. And obviously, they're only going to use that when their condition is acute, needing immediate attention. And oftentimes by then, it's either too late or it's going to be very expensive to treat it. Medical bankruptcy. Bankruptcy, by definition, is the inability to pay your bills, simply put. Medical bankruptcy means that you have got into that position because of medical bills. Now, let me give you some numbers about this. And these numbers come from 2009, just before the Affordable Care Act. 62% of all bankruptcies, all personal bankruptcies in the United States, were because of medical bills. About 900,000 people in the United States in 2009 went broke because they couldn't pay their medical bills. 75% of those people had health insurance. Think about that. 675,000 people in the United States in 2009 who were covered by health insurance, private health insurance, went broke because of medical bills. That's an inadequacy, certainly in the coverage. We'll talk more about the uninsured in a minute, but that's another feature. Again, we're looking at these general patterns of health-related behaviors in the United States, given our private for-profit system. We're going to take a look at some data. This is the Kaiser Family Foundation. This is one of the best places to get data about health insurance, about people's health-related behaviors, and so forth. You can see they have some trending topics. Of course, the coronavirus, the election, the Affordable Care Act, all up here. We're going to take a look at this. Key facts about the uninsured population. So we're looking at the number of uninsured and uninsured rate among the non-elderly population from 2008 to 2018. I'll tell you right off the top, I do not like that phrase, non-elderly population. It's the population under the age of 65. Those that are 65 and older are being referred to as elderly. I don't like that designation. But in any event, the reason why they make this distinction is because when you hit 65, you're eligible for Medicare, which is government-provided, federal government-provided health insurance for people 65 and older. So they're not part of the private system per se. In any event, that's why they make this distinction. So we can see in 2008, 17% of the population was uninsured. A total of 44 million people that were uninsured. Right, these are in millions. 44 million people, and you can see how the numbers increased. Then 2010, the Affordable Care Act begins. The numbers remain high because people weren't required to get health insurance immediately. The mandate to get health insurance kicks in 2014. And there you see the big drop from 2013 to 2014. From 16.8% of the population being uninsured to 13.5%. It drops again, it drops again, and then it rises 2017, 2018. Here you had the Obama administration pushing people to get health insurance, making it as easy as they could for people to get health insurance. The Trump administration has taken an opposite approach, and consequently we've seen the numbers click up from 10% to 10.2% to 10.4% of the population, from 26 million people, nearly 27 million people, to nearly 28 million people. So we're seeing this increase in the numbers of people that are uninsured. Again, keep in mind, I've made this point before, the way governments implement policy is going to have a major effect on the efficacy of that policy. We can see that the change in the uninsured rate by selected characteristics. We see that poor people saw their uninsured rate drop as more people were getting onto Medicaid, but other income levels saw their uninsured rates click up. Whites, blacks, and Hispanics saw their uninsured rates click up. Asians and other smaller groups saw their numbers decline. We have now more children as a percentage without health insurance, and more non-elderly adults as well. This is the uninsured rate. So anything that goes up indicates an increase in the uninsured rate. This is interesting. Characteristics of the uninsured. 72% of the uninsured are in households with at least one full-time worker. At least one full-time worker. And people are uninsured. We're looking now at a percentage of FPL, the federal poverty line. So about 23% of the people under the federal poverty line are uninsured. About 28% of the people with income up to 200% are uninsured. Up to 400%, a third are uninsured. And those who make 4 times the federal poverty level, 16% of those people are uninsured. So it cuts across income levels, and it cuts across demographic groups, racial and ethnic groups as well. All right, here we see we do a better job insuring children than we do insuring adults, which some people would say is a very good thing. It would be nice to do a good job insuring everybody, but certainly this is our most vulnerable populations are our children and our senior citizens, and we do a better job at covering them than we do at covering adults. And you can see that here cuts across groups. But look, blacks, Hispanics, the minority groups are more likely to be uninsured than are whites or even Asians. Expansion state, non-expansion state. I'm going to explain what this is, and then we'll see some more data about it. One of the ways that the Affordable Care Act sought to get everybody covered was to expand Medicaid. Medicaid is health insurance for the poor, and it's a hybrid. It's administered by both the federal government in partnership with the states. States get to set eligibility requirements within reason, and those eligibility requirements are largely income requirements, although they're kind of sneaking in other kinds of requirements as well. But basically it's income requirements. The state will pay a portion of the Medicaid costs in their state, and the federal government will pay the balance. What the Affordable Care Act said was expand your eligibility to cover more single adults, especially non-parents, cover them, and the federal government said we will pay the total cost of that for the first, I think it was 3 years, and then at least 90% of the cost of that in perpetuity. States filed a lawsuit. States led by Republicans filed a lawsuit. Went to the Supreme Court. Supreme Court said the federal government could not mandate the states to expand their Medicaid coverage. So consequently, some states expanded their Medicaid coverage, states that were run by Democrats, and states that were run by Republicans, by and large, did not expand their coverage. As a result, we can see the uninsured rate of the non-elderly is much higher in states that didn't expand their Medicaid coverage than in states that did. It's almost twice the rate. That's what that refers to. Again, how you implement policy is going to impact efficacy. Here are the uninsured rates, state by state. The light color blue, less than 7% uninsured. States like New York, Vermont, Connecticut, New Jersey. There's 15 states that have uninsured rates under 7%. The middle color, states with uninsured rates between 7 and 11, 14 states. Then 21% of states have an uninsured rate that's greater than 10%. That's the states in the dark blue, and most of these states have not expanded their Medicaid coverage, did not take advantage of federal dollars to get more of their citizens covered by health insurance. And consequently, more of their citizens are uninsured and pay the price, especially now. During the midst of this pandemic, access to health care is becoming crucially important. And some people have it, and some people don't. Reasons for being uninsured, not surprising. The cost is too high, or they either lost their job or they changed employers and they lost their coverage, or their income crept up a little bit so they were no longer eligible for Medicaid, and they lost their coverage there. But by and large, it's this one. You can't afford it. We're going to look at this in a different graphic, but let me just kind of point out what this one means right here. Right, eligibility for ACA, the Affordable Care Act, coverage among non-elderly insured. Tax credit eligible means that your income is at such a level that you can get a subsidy. The government, the federal government, will help you pay for your health insurance. These are people that are poor and they get expanded Medicaid. These are other Medicaid patients. And then here you have this. In the coverage gap, 2.3 million people. The way the act was set up said that if people's income went from 0 to about 130% of the poverty line, they would be eligible for Medicaid under the expanded Medicaid. If their income was from 131% of I think it was 133% of the poverty line, up to, I don't know what the top level was, maybe 300% of the poverty line, they would be eligible for subsidies. And then people whose income was high enough would not be eligible for subsidies. The gap that they're talking about is the percentage, are people, and this is counterintuitive, people whose income was too low to get a subsidy. The subsidies would start at 133% of the poverty line. If a person's income was, let's say, 125% of poverty, if they were in a state that expanded Medicaid coverage, they would have Medicaid coverage. If they were in a state that didn't expand Medicaid coverage, they wouldn't be eligible for Medicaid coverage. But because the way the law was written, They also were not eligible for subsidies. Their income was too high for a subsidy. Interesting. But it wasn't low enough in those non-expansion states to get Medicaid. Now, you should be thinking, well, that's a pretty simple fix. Just change the law. Remember, you don't have you did not have majorities of people in support of the Affordable Care Act being successful in Congress. You had majorities in the Congress who wanted the Affordable Care Act to fail. And therefore, they weren't going to do anything. I'm talking about Republicans. They were not going to do anything to try and improve the bill. In fact, the Republicans in the House of Representatives for years passed bills that would repeal the Affordable Care Act. And they never could get them passed in the Senate. And they certainly were not going to be signed by President Obama. They continued to do that in the first year of the Trump administration, and they still failed to do that. So you have this. So we currently have nearly 28 million Americans who are uninsured. We don't need that one. And this is also obvious. Okay, I'm going to close this. You can take a look at that in more detail if you like. Now, how would Medicare for All change our healthcare system? How would it change, a better way to say that, how would it change these health-related behaviors in the United States? It would change the system by eliminating private insurance companies. And you would have what's called a single-payer system. And that single payer, that single insurer, would be the federal government. So instead of having to wait until you're 65 to get Medicare, you would have Medicare from the time you were born. And everybody would be covered. In the film Sicko, that's the type of system that they have in Canada. Very similar to this notion of Medicare for All, a single payer system. How is that going to affect the healthcare behavior in the United States? Well, I'm going to go through these point by point. Doctors and hospitals are still going to operate as businesses. It's not going to change. Private doctors, private hospitals, that's going to remain. Treat only those with the ability to pay. Everybody will have the ability to pay because everybody will be covered by the insurance. The fee-for-service system could very well change. That would be up to the federal government and how it administered Medicare. Right now, Medicare is fee-for-service, but it doesn't have to be. Insurers determine what tests are allowable. That's still going to be true. However, those decisions will not be made on the basis of profit. Those decisions will be made by Medicare, the Medicare system, who is accountable to the voters, as opposed to private insurance companies who are accountable to their investors, their boards of directors, and so forth. So it gets back to that continuum of market freedom. Do you want decisions being made on the basis of profit, or do you want decisions being made on the basis of the common good? And that would be a significant change. Drug companies are still going to do these things, but they're not going to be able to charge, well, the highest possible price is going to be the price that Medicare will pay for it. Because the insurance that people have is going to be Medicare. And Medicare is going to have tremendous power over drug companies in terms of the prices that they can charge